all of us know Dr. Waingankar is very senior pediatric surgeon and one of the first student from the KEM hospital. Joined, I
I
think, in
start talking.
1970,
Thoda
71.
sa. And
Uh, and he has vast experience of 50 years plus of pediatric surgery. And he will tell his experience with pediatric surgery. Dr. Waingankar.
good evening, everybody, and greetings at the time when the problems around are quite a lot. And in last 55 years of my pediatric surgical work, this is the first time we have to meet in such a electronic online way. In short, the pediatric surgery, see, I'm not going to be philosophical. I'm not going to be telling number of stories and experiences of the work done abroad and all that. I'm trying to go down to brass track where we started and how we started and what happened gradually and has reached such a stage now that we are talking about robotic surgery and laparoscopic surgery and all that. So example now, this specialization started or was born in 1972 at Mumbai University. Before that, Calcutta with Subir Chatterjee and MS Ramakrishnan in Madras, they were the two universities running the course of pediatric surgery. After it was started, almost for 30 years, it was one of the choicest options given by the postgraduates coming in. But now in 2020, we find only about 70% seats filled all over India. Gradually, number of problems come up like medical, legal and other things. And the subspecialties are encroaching, but neonates and infants continue to be
Hello. Hello. Dr. Waingankar. I am going to mute everybody and then unmute Dr. Waingankar. Dr. Waingankar, please start.
Can you hear?
Yeah, I can hear you. I muted everybody.
Yeah. Now, but have you heard the earlier section, what I said? We are talking about, we'll have to stick to devotion, gentle and correct approach so that we can continue our work. And definitely neonatal surgery, laparoscopy, robotic surgery have got a promising future. Obviously, what I am trying to tell you, these are my personal comments and I don't want any discussion on that. Next. Our tributes to two people, particularly in KEM, Dr. R.K. Gandhi and Dr. R.A. Irani in JJ Hospital. These are the two places where the specialty started in the beginning in Mumbai. I am not going to talk much about Dr. R.K. Gandhi, but one thing is certain, that he was excellent, knowledgeable, memory was excellent. He had very good organizational skill and he could get anything done from any of the assistants, colleagues, students, or even his own enemies in practice. He had a national, international reputation and he was a teacher and guide to most of us. Now, why I have written the 1929 is the date, I mean, year when he was born. 1967 is the year we started pediatric surgery at KEM. By 1972, it got recognized for MCH. In 1987, he retired, and 2003, he expired. The most important point I have put on is 1972. Mind you, you have seen in his conditions when he was practicing and teaching. From 1973 to when he was 43 years old, he was struck or he was diagnosed as Parkinsonism. His father had the same problem much at older age. And what you have seen him, or what I have seen him all along, that he achieved most of his work because of his whatever devotion to the branch and the teaching that he achieved after he developed Parkinsonism, and continued working on even computer and all that during all this time. Except for the present people who are attending and some of the others, except for the first generation pediatric surgeons from KEM and from JJ, most of you have worked in developed pediatric surgical centers, either India, Mumbai, or abroad. For me, in 1967 and 1969, when I started working in pediatric surgery, 3 years before it got recognized and the MCH came in, the conditions were very primitive regarding instruments, equipments, trained nurses, experienced anesthetists, and more important, the residents. And residents that time were coming from gynec stream and from pediatric stream, because somehow or other the general surgery was not allied to pediatric surgery posting till 1972 when we got the teaching status. So all our 3 years or 4 years of residents were coming from pediatric surgery, and they are practicing in Mumbai as either gynecologists or pediatricians. Problem that time was basically starting, which already I think Josna had commented, that it has started with IV line. You can see here, this is a Romson Scalfven needle available that time, which had instructions says you have to boil them and use them. And mind you, we were reusing them. Along with that, the imported gamma ray sterilized veins, the scalp veins are there, which obviously was much costly. And I think that time we used to try to save patients' money or municipal corporations' money in the teaching hospitals. The needle which you see here, the needle which you see here, which is with a plastic tube, is a indigenous way of doing a splenoportogram developed by Dr. Balera, and it was used all along till the time the whole system of radiology and imaging changed. Then obviously there are three air speculums. They were used for directly cauterizing the posterior of the wall in the absence of the scopes available through perineal urethrostomy. Obviously, there are two record syringes, one BD syringe, which you don't see them now, use them now because of the disposable syringes and the problems which are totally changed. There's one more small retractor, which is a Park's anal sphincterotomy retractor, and I don't know how many of you have used. Very excellent retractor for doing a sphincterotomy by stretching the posterior wall almost up to the anus. Then comes fiber optic. There's nothing like fiber optic cords that time, and we had to depend on the step down transformers and use a light source, which was definitely not so good. And it is to be at the end of the scope. It is to be at the end of the scope. You can see below there's a black spots there, which are basically showing you the bulbs which are at the end of the sigmoidoscope. I couldn't get the pictures of any of those scopes which were used that time with battery operated and all that. But I thought I'll just at least show this. And then comes obviously now the present scopes which are totally different. Surgery of neonates, infants, bigger children was totally different. You all know it, but possibly we have practiced it that time. It was totally different, and gradually it has changed over. And what you are seeing today is the present, obviously latest. Maybe some changes will occur in future. So I'll quote a few and try to discuss a few, but I will not go into the detail because there are too many. The this talk of today's particularly came up because we were talking about urinary diversions, and those days we had hardly any scopes, we had hardly good antibiotics, so we had to resort to either ureterostomies and vasicostomies, and the problem of undiversion was considerable after once you do the diversion. Now, gradually, because of the changes, now it has become less. I agree with you. But my personal opinion was those days I found vasicostomy was much better for infection along with high creatinine for posterior throat particularly. And I have now patients almost 30, 35 years old who have been subjected to vasicostomy in the neonatal period. And then when they were a little bigger, scope the wall fulguration and other management was there. Somebody already commented TOF had a high mortality almost till end of 70s. Suture material was a great problem. Everything was this different because of the suture material. We used to have catguts, chromic and other ones. We had sutupac, silk and white nylon, which was also had to be needled. Only one consolation was the Johnson and Johnson came out with 100 linen on a needle in sterile pack, which we used to use for intestinal anastomosis, the innermost layer. And on top, we were either using catgut or silk. And particularly, this was in neonates and small infants where the anastomosis was. Obviously, it used to be interrupted linen sutures for this purpose. IV complications, septicemia, bronchopneumonia, and scleroderma were pretty common in spite of all the cares taken. One more important thing, which I'm not going to go into the details, the basic concept of treatment and timing of undescended testes and hypospadias was totally different. I still remember as a houseman, my boss in general surgery showing me correction of Cordy. And what I recollect now is that he took a transverse incision on the undersurface of the penis, skin, maybe subcutaneous tissue. He hardly went anywhere, raised those flaps and closed it in the longitudinal way. I don't think I'll blame him because the training and everything was at that time, the things were not developed. What we used to have, which has become less now, is a staff. We used to have a lot of staff employments, almost ward having about 3, 4, 5 patients with IC tubes. They were not worth going for, or maybe we were deficient in taking them for open surgery. And staph osteomyelitis, those we used to admit those patients with osteomyelitis. And obviously, staph cysts, which were at times almost sterile cysts and will remain for a long time without problem and gradually disappear by reducing on its own size once you have controlled the infection. you can see here few things. You can see on the right side, there is a osteomyelitis of the upper end of the tibia. You can see below that, upper end of the femur has got an osteomyelitis. And another thing which was common that time was necrotizing fasciitis. This is the earliest stage of necrotizing fasciitis in a possibly a neonate. Next, obviously, is enthusiastic warming of a neonate in a labor room, which has resulted into burns. Then comes some of the things which are totally changed. We had, I think Bombay got sonography around 79. Before that, obviously, you can see the C on the right side. There was no sonography. There was a huge cystic lesion on the left side of the girl, big girl. IBP had no function. Obviously, we had no sonography and all that, so she was explored, and you can see we are talking about laparoscopic, transperitoneal, extraperitoneal, PUJ obstruction, and you can see such a huge kidney with the fluid which is already absorbed was in the tummy, and it required obviously nothing else than nephrectomy. At the same time, we used to do nephrectomy regularly for multicystic dysplastic MCDK. And this particular specimen, you can see the atretic ureter, which is the cause of the MCDK. All these were stopped because a huge number of conservative cases and came in literature. And nowadays, they are known to shrink on their own. Only you require observation for them for bleed. Cancer is supposed to be very less common, but you can see the size decreasing because of the vascularity as such is very poor. Then comes another topic, which we are forced to do it because of absence of ventilators and other supports. I'm sure you can always say this is the upper picture on the left side is a recently closed omphalocele which has got covered. We have only closed the skin after stretching the abdomen and putting the contents in the back for the sake of breathing problem not to be there or pressure on the diaphragm. So this is the early one, while the other one is you can appreciate what is the problem of the ventral hernia there, along with the additions of the scar to the right lobe of the liver, huge distended abdomen with bilateral hernia. It required obviously correction when the child was older, but we had a surviving child. We have a surviving child. In these particular cases, what we used to do is excise the sac, stretch the abdomen, and try to do repair in the center. Quite often, we used to take the rectus from one side at the upper end and put it to the other side and reflect the rectus sheet from lateral side, both sides, and bring them together and do the repair. Hypospadias. I am not going to discuss because I think hypospadias I was told when I was in anatomy as a lecturer and I used to teach them, we should operate them around 12 years when the size is increased and you can do a better repair and all that. By the time I came for practice in 75, the hypospadias surgery, the timing had come to about 3 years in 75 or so. Gradually, it has come down to 1 year or even less than that to 6 months. I'll not go into the details there. Why I have shown this is suture material. The suture material, there was no Vicryl or type or DPS, all those newer suture materials. So we had to use fine um, ethylone as a continuous stitch coming in from either glans but mostly from scrotum, and take it out of the glans and leave it there with the upper layers being closed as what we do with whatever the catgut or silk and all that. This one will possibly retain for some time, and you may escape without fistula. The that stitch had to be pulled out from scrotal end around, say, about 2 to 3 weeks time. All these are few of the things which we were planning. Obviously, this is just another case where now the propranolol has come and number of things have come. But an excellent result with oral steroid in this child. You can see the same child at 6 months and 13 months minimum still has got some lesions which are not need not be treated. Now came subspecial, pediatric medical subspecialties. They were still to develop during the time when I was there in KEM. So chemotherapy, failure, renal failure, hepatic failure, everything we were managing in consultation with the physicians, either adult or pediatric physicians. Endocrinology had already come, but there were no proper drugs like octreotide. And I still remember I had done 5 almost total pancreatectomies for nesidioblastosis, which obviously now has become less because of medical management and good endocrinology cover-up. We were managing head injuries. I was talking in the first slide, I had said our work is shrinking because of this other specialties taking over. Head injuries we were managing in KEM and at HN almost up to 90s. And then obviously because of the medical legal region and other problems and consumers and all that, we are almost as good as stopped managing the head injuries. Now for the KEM people, particularly as a nostalgic memory, the KEM ward was originally above JMT and additional beds were there in Ward 2 in second floor. It was in 1970 that Dr. Gandhi and Mrs. Deshmukh managed to get the present ward on the terrace of Gynec wing, but there was no lift going there, and it was a round, small staircase on which the patients operated, unoperated, for investigation had to be taken up till late 70s. This lift came up to the third floor where the pediatric ward is presently there. Is renovated twice, once earlier and recently by the present Dr. Parulkar as the head. Then next your question will come, what about IPCU? First KM intensive care unit surgical was there in a 12, say roughly 12 by 12 room at the entrance of the ward on the left side. It had 2 beds, one nurse, one oxygen cylinder, suction machine, and basin. Nothing else from that. This is where we started our IPCU, and you can imagine what is the status now. This IPCU ward was started in 1971. After you enter the ward, I had put up a notice board there. Obviously, this is the slide made of it, is that for the houseman, when he enters the ward, in absence of monitors, reliable, unreliable nurse, I had put up a board that from a distance they should see the breathing, see the color of the child, then feel the anterior fontanelle, feel the cheek for the thickening. The earliest scleroderma starts from, I don't know how many of you have seen or managed. Earliest scleroderma starts from cheek, then it goes to arms and then further up to the chest. You feel for the cheek and then auscultate rest examination and intake output chart and other things. So that was the state of affair that time. And now, obviously, this is not a KEM, but this is a symbolic way to say you may have even a better IPCU or NICU for our present children. In short, The clinical examination and clinical diagnosis was most important. With your own eyes, ear, and a history taken. Because available facilities apart from the biochemistry, we had only X-ray and at the most tonogram during those days. So all your clinical challenges were there for diagnosis and then obviously management. Histopathology for biliary atresia and Hirschsprung, I don't know how much better it is, but it was a problem that time with no unanimity amongst the people opining, on which we totally depend on surgical procedures. Another domain where pediatric surgeon was totally managing that time was exchange transfusions in newborns. Exchange transfusions used to come usually around 2 o'clock, 3 o'clock after 1 or 2 bilirubin repeats had gone up, and pediatric surgeon will be doing that with no cardiac monitor or pulse oximeter. We used to borrow the fetal monitor in obstetrics where they used to keep it on the expectant mother to hear the heart sound. That was giving a beep, beep, beep sound. We used to keep it and fix it on the chest of the newborn and do the exchange transfusion. I don't know what is your opinion and what you have followed regarding neonatologists and pediatricians. We were happy-go-lucky people that time who would get up at 3 o'clock and do the exchange transfusions. So we were managing it. Obviously, we had no regrets. But gradually, the gynecologist started feeling, we have the patients and we have a section of neonatology. So you mind you, they started taking up the exchange transfusion patients and calling us when they couldn't introduce the umbilical line. And those days we used to have uh, sets available, sets available, ready sets available with all those facilities for exchange, which are disappeared now and is not required. And most of the exchanges were taken over after the gynecologists. Obviously, we were carrying on. I had also done it in British Candy also after I came in practice. But later on, the pediatrician neonatologists started doing it, and they are doing it in NICU. We were doing it in OT, in with a good nurse and good preparation. After talking about this all clinical problem, I think I'll talk a little more about myself or the conditions where I was working. My career is from KM Hospital, went to in private to HN Hospital and Wadia Children's Hospital. I'm sorry. Rajawadi Hospital, Municipal Hospital, where there was a good pediatric ward and general surgeons were managing all along. They allowed me officially to have 4 beds. Obviously, I was a general surgeon because there was no posting there. They allowed me to have 4 beds, separate OPD, and obviously a separate houseman for pediatric surgery. And I tried to do whatever I could manage there in some conditions. One situation I remember, I came out of Rajawadi Hospital OT and went to railway station to go home. That was about 3 o'clock in the morning. I had just finished one diaphragmatic hernia done by a subcostal incision. And obviously, as I told you, I had done only closure of the skin and put everything back. The child was alert, anesthetist has helped, child was conscious. Now, how to keep the child breathing and maintaining? Because there is no going to be any observer, nurse, and those problems are there everywhere. I remember I told the mother, go on pinching the child every 5 minutes. He should cry and all that. You mind you that patient went home with obviously with a ventral hernia. But this was the state of affairs we started working. and we continued working. From Rajawadi, the benefit I got about was three of the residents there were working with me. They possibly felt something regarding pediatric surgery and chose it as a super specialty. One is Vivek Rege, second Dakshesh Parekh, and third is obviously at present with us is Rakesh Shah. After Rajawadi, I came to Wadia Children as a teacher in uh, MCH pediatric surgery in 1988, and we got a registration and all that after that. And we had even the students from all over India, including obviously we know Dr. Ramesh from Bangalore and Dr. Naregal from Baroda are some of them. After I came to Wadia, I was benefited by three lecturers who came from KEM. All of them big stalwarts. One is Dr. Oak, second Sarita Bhagwat, and third is Manish Patel from Indore. So I had good experience of their lecturer help for me all along. But I think I was bestowed with excellent residents in KEM during the initial period of difficulties of development of pediatric surgery. And I quote a few, maybe I'll miss a few. One is SSB, commonly called as SSB Dr. Waingankar, Dr. Bharti, Dr. Josna, both of them are here. Late Dr. Fadke, Dr. Dilip Shah from Ahmedabad, and from outside, we had Dr. Jain from Bhopal and Senior Dr. Waklu from Lucknow. I think we all of them have excelled in their field. I don't say that I am the reason behind that, but they have definitely helped me during the difficult time. One thing is certain that I was very nice to them, but I was strict regarding clinical diagnosis and management. For example, the registrar on duty in pediatric surgery had to have a diagnosis checked and corrected by me. And if I find the diagnosis is wrong, I'll operate. I'll not let him operate. So the responsibility increased on that and possibly indirectly helped them in their future. I have not talked much philosophy of Dr. Bharti's type, not much big stories like Josna, but I was on a brass track of how we came up at this particular stage. I wish all the participants, particularly those who are now trying to uh, go into different super specialties in pediatric surgery, I would like to give thanks and I brought some of the pictures of the people who have worked with me. Maybe I have missed a few, but I think I owe them a lot because ultimately it's a joint work which is essential for management of small children. I regret regarding Dr. Dilip Fadke. We had very good equation during his time and even later on. He's no more with us. And all these people, I think I thank you. I'm sorry if I missed a few who have worked with me. Two things I would like to mention. We were talking about the topics and all that. One topic is, which was already spoken about, but I had already written earlier, the mistake which I had done in, maybe you can say, big mistake which I had done in treating pediatric surgical patients. And second thing, mistakes done by my juniors. That is more important because I am responsible for them. So these are the two topics, obviously, which can come up later on in future. I think if you is there time, 2 minutes, Dr. Rasik, is there time?
Yeah, you can
I would
speak
like to
very.
state after I went into Arkesan and little modern equipment wise, there were few things which were still not complete for neonates and pediatric surgery. In one child, neonate who had a massive bleed. We suspected malariasis and we treated. Now, how to confirm it? Dr. Um, Dr. Shah, I forget his first name, uh, he suggested that he has a new colidocoscope, which was half a centimeter or so in size, with only one directional movement. So he told me he will try that. And he did it, a scopy for that child, OGD scopy, and we found a nicely healed, almost scarring ulcer along the length of the gastroesophageal junction to confirm that. Second was the same pediatric, same gastroenterologist was now having a colonoscope and he was doing very well. He had done one or two colonoscopies for me for rectal polyp. Then he got his equipment for the polypectomy, and he's, I referred him a patient of a high polyp is not able to reach, suspected polyp. Obviously, we cannot do unless they do the scopy. So he agreed to me that, okay, I'll come to OT and under anesthesia in lithotomy position or whatever position you give me, I'll put in a scope and, and see the polyp. Mind you, he saw the polyp in the high rectal area, but he had no confidence in polypectomy that time. So he asked me that I'll keep the light source there. Now, can you feel he asked me to open up the abdomen. I opened the abdomen. I felt the light source. I felt the polyp. Then he withdrew the light source. I mean the scope. I took an incision there and I took out the polyp. Idea of telling is that we are all learning procedures. The person, S.C. Shah, Sharat Shah, sorry, I mean, Sharat Shah. Sharat Shah is the one who was concerned with both these episodes. He was very cooperative and nice to me, but innovative. And mind you, I don't know how many of you know that all colonoscopies were done in X-ray department, trying to see how is the scope going. That was their learning years. Obviously, now they can do it in OPD procedure also. But these two instances, I remember being, in spite of coming to a modern place, we had difficulties. Thank you very much. I think.
Thank you, Dr. Waingankar, for very enlightening talk. Can you stop sharing, sir,
Yeah,
so that we have full screen?
I'll just try to disconnect.
Yeah, it was excellent talk. How you practice and how you started working and how the advances has happened. We have already crossing 1 hour 45 minutes. So before we conclude the day, like Milind Chitnis, who is from South Africa, to say few words or few minutes, and then Ramesh from Bangalore, and then we'll call it a day. And we will continue learning from seniors. Maybe the format may be changed. Maybe we'll have only one person at a time, so we can finish it an hour or so. Milind, you are on. Milind, yeah, please go ahead.
Yes, Rasik, thank you very much. It is so nice to be able to see and hear all the teachers. The last time I heard Dr. Mrs. Kirtane, Dr. Waingankar and Bharti Kulkarni madam was probably 1988-89 when we used to have the joint Bombay Pediatric Surgical meetings either at KEM or in JJ Hospital. And I think mentorship is absolutely essential. It is essential to have good mentors and good guides for you. And Rasik will agree with me that we were fortunate to have mentors like Dr. VCT, Kirtana Madam, and Dr. Mane. I mean, I was there from 1987 to 1990, and we had only one ICU bed for a newborn patient. We had a very tiny Lusco ventilator. We did not have ultrasound facilities at JJ Hospital. We used to send patients to Dr. Naoshi. And despite of that, what we learned was being a good children's doctor who can do operations safely and who knows when not to do operations. And everybody will remember, those who know Dr. VCT, that he used to call our department as Department of Surgical Pediatrics. So we are the children's doctors who can do operations for them. And I think it is very important for us to remember from where we started. And Rasik calls me from South Africa. I call myself that I am from Pune and proud to be a JJite, and now living in South Africa for last 25 years. So I think those are the memories and those are the foundations, and we have come a long way. But I think if you have a strong foundation, you can go on building, and learning never stops. So we still learn, but I think the pillars, the people who showed us the path, guided us on the path, are the teachers. And it is so wonderful, Rasik. Your initiative is highly appreciated, and I will like to participate in future meetings. This is the best use of technology, that's sitting anywhere in the world. We can listen to experts, we can share our ideas and learn from each other. Because I still remember I learned a few things from Rasik, who was my junior registrar. So there is no harm, you can learn from anybody and everybody. Thank you, everybody. Thank you, everyone. It's really wonderful to be part of this meeting.
Thank you, Milind. Thank you. Nice to see you. And now we will have Ramesh from Bangalore. He wished to say something to us. Ramesh, you are on.
Thank you very much, Rasik.
Yeah.
It's been a wonderful to listen to all my seniors, including me, including you. Okay, lovely. Dr. Josna Kirtini has done lots of important points, and it was wonderful listening to her. She's been very influencing in a lot of my ideas, because she was very open-minded even those days. She was wonderful. She was great, and the way she put across and the way she did was fantastic. Arthi Kulkarni has been extremely open and really inspirational to all of us. Dr. Waingankar, sir, you have been my teacher, and I cannot express my gratitude enough. You've been wonderful. You've taught a lot of things in life, not just about surgery, but about our and special thanks to Rasik for all your efforts. Great. Please continue, and we are always with you. Thank you, Rasik.
Thank you. Thank you, Ramesh.
Can I say something about Dr. Waingankar?
Yes, madam.
When I joined as a houseman, he was the one who taught us how to be nice to your juniors, you know. That is very, very important. Once I was feeling giddy, and then he said, come on, now if you are feeling better, because you are going to operate on this case. The second thing, he never made us pay for when we went to canteen. So we are following your footsteps, sir, that we are kind to juniors. Maybe my juniors will not agree. But he was very, very nice to us.
I think it is very important for having a good experience of postgraduate residency. If you have good colleagues, if you have good seniors, as well as good juniors, I think the life becomes much simpler. And I think those who have colleagues who are not good, they will know how much problematic it can be. I think if any one of our faculty members wants to say a line or two, please go ahead, and then we'll close the session.
Can I, Rasik?
Yes, ma'am. Yes, ma'am. Yes, madam.
Do you remember the parties we used to have at Haji Ali once in 6 months?
Yes, ma'am.
and your stories.
Yeah.
So I think, you know, all the hard work is important, but I think some time spent in fun and that brings everyone closer, I think.
I agree with you. Yes, ma'am.
We get close.
Yep.
One thing my dean had told us, that as you become boss, the thing which you lose is you no more can curse your seniors.
Thank you, ma'am. I think it was a wonderful session. We will continue with our series of pearls of wisdom, and
What will be the next? What will be the next?
next one I will declare in couple of days. I have not spoken to anybody. I'll speak to somebody, and we will have, I think, make one or two. I don't know. Well, let me figure out so that we can finish it an hour. Because if it stretches more, then people,
Interest goes away. Interest goes away.
yeah. Thank you, everybody. I'm going to close the meeting. Thank you.